Hello everyone. This video will be useful for you to learn about and get oriented with the Vesico-vaginal fistula. Myself is Ruth Kezia, working as a lecturer in MMM College of Nursing. Objectives will see about introduction, definition, historical background, epidemiology, etiology, risk factors, pathophysiology, classification, clinical features, management, surgical management, postoperative care, complications, prognosis, prevention, public health importance, and conclusion. Introduction. Vesicovaginal fistula is an abnormal epithelial-lined communication between urinary bladder and the vagina, resulting in continuous and involuntary leakage of urine into the vaginal canal. It is one of the most distressing urogenital fistulas, causing profound physical, psychological, and social consequences for the affected women. Vesicovaginal fistula is largely preventable and it is considered a marker of poor obstetric care in low resource setting. So vesicovaginal fistula, it is an acquired one, okay, especially after a pelvic surgery or after a trauma, okay, or after a childbirth. The woman gets this vesicovaginal fistula where the urine comes out through the vagina. So the urine, when it is coming out through the vagina, we cannot control, right? So there is no sphincter muscles there in the vagina. So it will be leakaging, okay? Continuous leaking will be there. It gives profound physical, psychological, and social disturbances for the affected woman. Through the vagina, unrelated to voluntary voiding. So if you see the picture here, there is a connection between the bladder and the vagina, right? So this is the bladder, this is the uterus, and this is the rectum. So this is the anterior part of the woman, and this is the posterior part. Of course, this is especially this is a sagittal section of our body. Okay, so this is the bladder, uterus, and the rectum. This is how it is situated. So there is a connection, pathological connection between the bladder and the vagina. So this is a uterus and this cervix and this is vagina. So there's a connection between the bladder and the vagina. So this is called as the vesicovaginal fistula. Vesico means bladder. Okay, vesicovaginal fistula. Historical background. Vesicovaginal fistula has been described since ancient times. In the 19th century, surgical repair techniques were pioneered, significantly improving outcomes in developed countries. However, vesicovaginal fistula remains prevalent in developing nations due to limited access to quality obstetric services. Okay. Next, epidemiology. Global burden. Approximately 2 to 3 million women live with untreated fistulas worldwide. Geographical distribution most common in sub-Saharan Africa and South Asia. Developed countries, it is rare, usually iatrogenic, that is hospital acquired following pelvic surgery. Age group, it commonly affects young women of reproductive age. Etiology, the causes are categorized under specific heading. First is obstetric causes. Under obstetric causes, it is the most common worldwide causes, and the reasons are prolonged obstructed labor, pressure necrosis of the bladder and vaginal walls, inadequate or delayed obstetric intervention. And second cause is the gynecological and surgical causes, that is due to hysterectomy, cesarean section, pelvic radiation therapy, pelvic reconstructive surgeries. And we have traumatic causes, malignancies, and infections. Under traumatic, we have pelvic fractures, sexual violence, instrumental injury. Under malignancies, advanced cervical or bladder cancer, tumor necrosis. Under infections and inflammations, there is severe pelvic infections and tuberculosis. Risk factors. So what causes vesicovaginal fistula? Early marriage and teenage pregnancy, because the bone is still growing and the perineal muscles are still growing. Okay, so there is a chance, and it is very tender, and there is a chance for injury to this perineal muscles and leading to fistulas. Okay, and malnutrition and stunted pelvic growth, and lack of antenatal care, home delivery without skilled birth attendants, prolonged labor more than 24 hours, and previous pelvic surgeries. Pathophysiology. So if you see in the picture here, the blue part represents um, the friction between the head of the fetus and the bone, okay, in front. So this bone is the pelvic bone, okay, symphysis pubis, and this is the bladder, and there is a pressure here. This is the fetal head, and this is the vagina, and here is the rectum compressed here, and uh, uh, this is the spinal vertebral column, that is the coccyx, okay, sacrum and the coccyx bone. So coming to the pathophysiology, first what happens is there is because of prolonged obstructed labor, the fetal head compressed against the pelvis, and compression of bladder and the vaginal wall will happen, leading to ischemia, that is reduced blood supply, leading to tissue necrosis and leading to sloughing of necrotic tissue 5 to 10 days, and formation of vesico-vaginal fistula and continuous urinary incontinence. So during delivery, there will be compression of bladder and the vaginal wall. If it is a prolonged and obstructed labor, it leads to ischemia. Okay, and even after the delivery, there will be because of that ischemia for a longer duration, it causes tissue necrosis and sloughing of tissue 5 to 10 days, and that leads to necrotic tissue will leads to vesico-vaginal fistula formation, and there will be continuous urinary incontinence. Classification flow chart of vesico. So how the vaginal fistula is classified? By size, it is classified as small, medium, and large. Small means the length of the fistula will be less than 1 centimeter. Medium 1 to 3 centimeter. Large more than 3 centimeter. By location, it is divided as juxtacervical, mid-vaginal, and juxtaurethral and trigonal. Okay, so juxtacervical means near cervical, okay, and mid-vaginal near urethral and trigonal. By complexity is classified as simple and complex fistula, including large, multiple, recurrent, radiation induced. So if you see the picture here, this is the vesico, number 1 represents the vesico-uterine fistula. So to orient this, this is the pelvic bone here, it is a bladder, this is a uterus, and this is a rectum. Okay, from front to back. Okay, so this is the bladder and this is the uterus. There is a communication, the yellow shaded here, there's a communication from the bladder to the uterus, so it is called as uterine fistula. The number 2 represents a vesico-vaginal. So here also the bladder is opened to the vagina here. Okay, there is a communication, abnormal pathological communication, so it is called as vesico vaginal fistula. Number 3 represents the uh, urethro-vaginal fistula from the urethra. So from the bladder, this is the opening coming out. Okay, this is the meatus, urethral meatus. So here from the urethral meatus to the vagina, it is communication, abnormal communication is there. So that is called as urethro-vaginal fistula. And number 4 is the rectum. So the shaded part is the feces here. So this is the rectum and feces. Can you, if you see the abnormal opening, you can see the feces coming out through the vagina. The yellow one shaded or the urine coming out through the vagina. Okay, so this is the number 4 represents the recto-vaginal fistula. And clinical features, vesico-vaginal fistula, under that we have urinary symptoms, local symptoms, and psychosocial effects. In urinary symptoms, there will be continuous urine leak, recurrent UTI. Local symptoms has vaginal excoriation, foul smell, and infection. Psychosocial effects will be social isolation and stigma, depression and anxiety, divorce or marital discord, loss of dignity. So imagine continuous leaking of urine, your dress getting soiled. Because of that, you need to wear an underpad or a maternity padded panties. Okay, you cannot walk freely. Without that, you cannot sit or sleep or anything. Continuous dribbling without any involuntary leaking will be there. So it leads to social isolation. Even the smell, you can imagine that. Okay, social isolation, stigma will be there. That leads to depression and anxiety and divorce. Even divorce can happen because of that, and marital discord and loss of dignity. Diagnosis. Clinical evaluation. Detailed history should be collected from the mother, obstetric history and surgical history. Speculum examination should be done to visualize the fistula, and dye test, that is methylene blue dye test, can be done. So the dye is instilled into the bladder, and we have to see through the vagina whether the blue color dye what we have instilled, methylene blue is blue in color. Okay, so whether there is any blue color discoloration, if you can see in the coming out through the vagina or not. So observation of dye leakage through the vagina should be noted. And if you see the picture here, this is a instrument. Okay, it is just like the uterine sound. Okay, both the tips are blunt. Okay, so this is the urethral orifice. From the urethra they are passing the instrument. It's supposed to go to bladder. Okay, it should not come out, but it is coming out. Okay, through the vagina it is coming out. So this is the uretero-vaginal fistula. The other diagnostic test or endoscopic and imaging studies: cystoscopy, intravenous urography, CT urography in complex cases, and urine analysis, culture, and renal function test. Coming to the management, under conservative management, there is continuous bladder drainage with Foley's catheter for early and small fistulas, and anticholinergic drugs to reduce secretions, and treatment of antibiotics for treatment of infections. So these three treatment will be the choice in case of early and small fistula. Okay, so this mucous membrane will join and it will be healed. Okay, the fistula tract can be completely closed if you do all the continuous bladder drainage and keeping the fistula dry, and anticholinergic drugs and giving antibiotics. Surgical management. So this is the definitive management. So this is the last option we have, and it is very effective also. Timing, when we are supposed to do surgical management after the inflammation subsides. So because of the urine leakage there will be infection and inflammation, and so this all has to be subsided. It should bring down by giving antibiotics. Usually it will take about 3 to 6 months, and after that only surgical management can be done. Surgical approach like vaginal repair most prefer, an abdominal repair and laparoscopic and robotic repair can be done. Principles for surgical approach are adequate exposure, complete excision of fistulous tract, tension-free watertight closure, interposition of tissue, that is example Martian flap. Martian flap is nothing but, you will take a piece of fatty tissue from the labial fat, and it is moved to cover a separate or a damaged area. Okay, so that is called a Martian flap. Taking a piece of fatty tissue, especially from the labial fat, it is vascularized. It should be vascularized. Okay, and we use that piece of fatty tissue to cover the damaged area. Okay, so that is usually you done in the rectovaginal, ureterovaginal, and vesicovaginal fistula. Post-operative care, prolonged bladder catheterization should be done 10 to 14 days, especially to keep the fistulous tract dry. So if it is dry only, the fistulous tract will get closed. Okay, and antibiotic prophylaxis, adequate hydration, pelvic rest, and follow-up cystography. Cystography means again instilling some dye into the bladder and see whether the surgery whatever is done, it is leak proof. Okay, water proof should be there. Okay, and complications. Recurrence of fistula can be there will be there's a chance of recurrence of fistula, and urinary incontinence, vaginal stenosis, sexual dysfunction, renal impairment. Prognosis: success rate is 85 to 95% for first repair by experienced surgeon. Prognosis depends on size and location of the fistula, etiology, surgical expertise, patient nutritional status. Prevention. So how to prevent this vesicovaginal fistula, especially that is occurring after some incident, after the childbirth and everything. So how to prevent it? Okay, primary prevention will be giving the antenatal care. It means grouping the putting the patient under high risk category, especially if there is any cephalopelvic disproportion. If you see the pelvis pelvis outlet and the head circumference, head biparatal diameter, it is more, means we say it is cephalopelvic disproportion, and we cannot conduct a normal delivery in that case. Okay, so that will lead to tension on the as we see in the pathophysiology, that causes tension on the bladder as well as from the into the rectum, and that causes ischemia, that causes necrosis and sloughing and fistula tract. Okay, so antenatal care and group identifying the women who are having cephalopelvic disproportion, teenage pregnancy. Okay, so all this should be identified and anticipated and put the mother under high risk category, and going in for the elective cesarean section, unskilled delivery during normal labor, and timely C-section. Secondary prevention will be after the once the fistula is formed, early diagnosis should be done, catheterization and referral should be done. Tertiary prevention, surgical repair should be done for complex fistulas and major fistulas, and rehabilitation and social reintegration. Okay, so these women's as it causes psychological effects also, so social reintegration is main thing in comes under tertiary prevention. Public health importance. Vesicovaginal fistula is not only a medical condition but also a social injustice. It reflects disparities in maternal health care access. Global initiative focus on for fistula prevention, surgical repair camps, and reintegration of the survivors. Conclusion. Vesicovaginal fistula is a preventable yet devastating condition that significantly affects women's physical, emotional, and social well-being. Early diagnosis, skilled surgical repair, and strong preventive strategies through improved maternal health care can substantially reduce its incidence and burden. So thank you all. We'll see you in the next video.